Welcome to Radiology Made Easy. Today, I'm reviewing selected axial images from a CT brain scan, both pre- and post-contrast. Firstly, there's a mass measuring several centimeters centered in the right parietal region. It appears to be extraaxial with a broad base adjacent to the calvaria. The mass is heterogeneous but predominantly shows high attenuation on pre-contrast imaging, and it contains areas of calcification. Following contrast administration, I can see patchy enhancement within the mass. In my usual practice, I would examine images on bony windows to assess for bony erosion or hyperostosis, but there's no gross bony destruction evident on these images. There's surrounding low attenuation, which could represent vasogenic edema. However, this edema extends to the cortex anterior to the mass and may represent an old infarct. There's no significant midline shift, although there appears to be mild effacement of the posterior horn of the right lateral ventricle. Additionally, I notice an abnormality in the left Parieto-Occipital region, characterized by homogeneous low density involving both gray and white matter, with associated loss of sulcal definition. No masses are evident here. The appearances are consistent with a recent infarct, likely related to the current clinical presentation and the indication for the CT scan. Further, paraventricular low attenuation aligns with small vessel disease. To summarize, the most significant findings I would convey to the referring clinicians include a recent left parieto-occipital infarct and a right-sided intracranial mass, with features most consistent with a meningioma. For acute imaging of stroke, there are a few subtle findings that should always be actively sought on unenhanced CT scans within 1 to 3 hours of arterial occlusion. These include: 1. Hyperdense artery sign, often seen in the middle cerebral artery or its branches. The MCA dot sign in the region of the Sylvian fissure should be checked for. The hyperdense posterior cerebral artery and basilar artery signs are also important to identify. 2. Basal ganglia obscuration. The basal ganglia, particularly the lentiform nuclei, are prone to early damage due to the end vessels of the MCA, making subtle hypodensity in this area critical to spot. 3. Cortical ribbon sign. This includes the insular ribbon sign, where cytotoxic edema leads to loss of the normal gray-white matter differentiation, particularly in the insular cortex. 4. Sulcal effacement. Look for this and other manifestations of mass effect. It's also essential to review the posterior fossa, as infarcts here can be masked by artifact from the skull base. Look for asymmetry, especially in unconscious patients. MRI might be necessary to clarify suspected posterior fossa infarcts. The cerebellar hemispheres are supplied by 3 arteries, so infarcts may present with a wedge of affected cerebellum. The brainstem can also be compressed by cytotoxic edema, necessitating a thorough check of cerebrospinal fluid spaces in the foramen magnum region. If the abnormality doesn't correspond to a vascular territory, consider the possibility of a venous infarct, checking the dural venous sinuses. Multiple infarcts of varying ages suggest embolic phenomena often originating from cardiac sources, especially in younger patients. In these cases, also consider arterial dissection. Cerebral infarction is one of the most frequently encountered pathologies by radiologists, making awareness of both common and subtle findings crucial. Stroke is a broad topic, and while detailed explanation is beyond the scope of this video, it's vital to have a systematic approach for reviewing CT scans of the brain to maximize detection rates. Always ensure there's no hemorrhage, particularly when considering thrombolysis for the patient. Thank you for tuning in to Radiology Made Easy. Remember, every image tells a story, and I'm here to help you decode it. Please share your thoughts and suggestions in the comments below. And stay tuned for more insights. See you next time.